morning everyone. Today's topic is intraoperative assessment of pulmonary valve. Coming to the introduction, a thorough knowledge of the typical anatomy of the right ventricular outflow tract, that is RVOT, the pulmonary annulus, the pulmonary valve, the sinotubular junction and the main pulmonary artery is essential in order to correctly interpret the various imaging modalities and to understand the range of pulmonary valve diseases. The pulmonary route, which is the part of RVOT that provides support for the leaflets of the pulmonary valve, is comprised of three sinuses of Valsalva, with the semilunar attachments of the valve leaflets proximally and the sinotubular junction distally. In contrast to the aortic valve, the sinotubular junction of the pulmonary valve is less prominent. The pulmonary valve sinuses are labeled in a relation to the aortic sinuses. The three sinuses can be anterior, right and left posterior sinuses, or can be right and left anterior sinuses and a posterior sinus. The semilunar attachment of the pulmonary valve leaflets forms the functional annulus of the pulmonary, and this demarcates the ventricular arterial junction. Immediately beneath this is the musculature of the subpulmonary infundibulum and also called as right ventricular outflow tract, that is RVOT. As you can see in the picture, there are left and right pulmonary valve sinuses and anterior corresponding to that left and right and anterior semilunar valves. The infundibulum positions the pulmonary valve in a higher place than the ventricular septum, which provides a superior benefit for a comfortable resection of the pulmonary wall leaflets during surgical procedures such as tetralogy of Fallot, without any hindrance of other cardiac structures, like in the Ross procedure also. In comparison of the aortic valve, the cusps of the pulmonic valve are held aloft by freestanding musculature with no direct connection to the muscular septum. They can also be defined by their relationship to a commissure found in the pulmonic and aortic valves and hence termed right adjacent, also known as right facing, left adjacent, also known as left facing, and opposite, that is non-facing commissures. The pulmonic valve, like the other three cardiac valves, is formed by endocardial folds that are supported by internal plates of dense collagenous and elastic connective tissue and are continuous with the cardiac skeleton. Coming to the different views of transesophageal cardiography, we generally routinely see in the operation theatre. One is midesophageal RV inflow-outflow view, midesophageal aortic valve short axis view, transgastric RV outflow view, upper esophageal ascending aorta short axis view, and transgastric RV inflow outflow view and deep transgastric RV outflow view. The first one is midesophageal RV inflow outflow view, where you can see tricuspid valve along with the pulmonary valve. The second one is midesophageal aortic valve short axis view, where only right atrium and right tricuspid valve sometimes can be seen. If the angulation is if the probe is a little bit angulated towards the right, pulmonary valve leaflets can also be seen. The next one is transgastric RV inflow outflow view, where we can see both tricuspid and pulmonary valves. And the other one is upper esophageal aorta short axis view, where you can see aorta in the short axis and pulmonary artery, main pulmonary artery in the long axis. Here sometimes we can even visualize RPA but not LPA. From the transgastric two-chamber view, if the transducer is turned little bit right, that is clockwise, will result in transgastric RV inflow view, that is also known as RV two-chamber view. The anterior and inferior walls of right ventricle are imagined in addition to the papillary muscles, chordae and tricuspid valve. The proximal RVOT is also frequently seen, and slight advancement of the probe may allow imaging and Doppler interrogation of the pulmonary valve. Coming to the various pathophysiologies, first is pulmonary regurgitation. Common causes include pulmonary hypertension leading to dilatation of pulmonary artery. Less common causes are Marfan syndrome, carcinoid from restricted leaflets, endocarditis, and congenital pulmonary stenosis, where surgical intervention might have occurred. 2D echocardiography reveals thickened, restricted leaflets, annular dilatation, vegetation, prolapse, and lack of coaptation. Doppler interrogation helps with a qualitative assessment of regurgitant jet width, length, and ratio of the jet width to the pulmonary artery diameter. Continuous wave Doppler of end diastolic flow velocity helps to estimate the end diastolic gradient using Bernoulli's equation. This estimates the pulmonary artery diastolic pressure. The slope of this regurgitant jet can be used to assess severity. A pressure half time less than 100 m/s may indicate severe pulmonary insufficiency. These are the parameters used to describe whether the regurgitant lesion is a mild, moderate, or severe. First is leaflet, second is annulus, and third is jet length, which can be measured by continuous wave Doppler, and ratio of jet width by RVOT diameter and continuous wave Doppler signal. These are various parameters which can be assessed to know whether the regurgitant jet is a mild, moderate, or severe. Coming to the next pathological lesion, that is pulmonary stenosis. Pulmonic valve stenosis is mostly congenital. In contrast, acquired pulmonary stenosis is uncommon and rheumatic pulmonary stenosis is extremely rare. Carcinoid disease cause combined pulmonary stenosis and pulmonary regurgitation. Rarely, primary cardiac tumors in the RVOT may cause obstruction mimicking pulmonary stenosis. Pulmonary stenosis can occur in isolation and, however, is most commonly a part of cyanotic congenital heart defects like tetralogy of Fallot, double outlet right ventricle, and others. Pulmonary stenosis can be at the level of valve, below the valve, and above the valve to involve the main pulmonary artery or the branches, and accordingly termed valvular, subvalvular, and supravalvular or peripheral, that is branch pulmonary stenosis respectively. In congenital pulmonary stenosis, the stenotic valve can be tri-, bi-, or unicuspid valve, and less commonly a dysplastic valve. The latter is commonly seen in Noonan syndrome. Subvalvular pulmonary stenosis can be infundibular or subinfundibular. Infundibular pulmonary stenosis is the main component in the tetralogy of Fallot, and subinfundibular pulmonary stenosis, also known as double chambered RV, that is DCRV, is seen in adults with a history of resolved ventricular septal defect. Supravalvular pulmonary stenosis can occur in isolation, is commonly associated with extracardiac abnormalities and part of genetic syndromes like William-Buren, Noonan's, Alagille's, DeGeorge, and Leopard syndromes. Congenital causes are most common. Other causes are rheumatic or carcinoid disease and RV outflow obstruction from infundibular hypertrophy and aneurysmal membranous ventricular septum. RV hypertrophy in these scenarios is generally seen, and 2D echo put forth thickened calcified leaflets with diastolic domain. Spectral Doppler shows color flow Doppler aliasing, and continuous wave Doppler reveals a late peaking dagger shaped envelope in the RV outflow tract. A peak gradient across the valve of 36 mm Hg is evidence of morderate stenosis. Coming to the various parameters which signifies the severity are two-dimensional leaflet morphology, right ventricle morphology, continuous wave Doppler, peak velocity, and peak gradient. If the leaflets are normal, RV is normal and continuous wave peak velocity is less than 3 and peak gradient is less than 36, then it is mild. If leaflets are thickened and moderately restricted with RV is mildly hypertrophied with peak velocity of 3 to 4 and peak gradient of more than 36, it will be moderate, and it will be deemed as severe if leaflets are thickened, calcified, severely restricted, and RV is moderately hypertrophied and peak velocity across RVOT is more than 4 and peak gradient is more than 64. Thank you.